Hello everybody, my name is Kyle Kravetz. I'm one of the residents at the University of Utah. I'm going to talk today about single ventricle management of patients. Rare subsect, but I think it's an interesting topic worth discussing. So first off, a special thanks to the entire faculty. There are currently, I believe, 1,500 applications this year for residency. And it has been a goal of mine to be an anesthesiologist since I was 19, and I'm extremely grateful for the whole department. You guys have been a tremendous source of wisdom, and I couldn't thank you guys enough. The cardiac and echo staff, Dr. Zimmerman, my mentors, you guys have been a tremendous source of resources and knowledge and people that I look up to in my career. For this particular talk, I want to thank Ned Morgan. He spent a lot of time with me putting this together and helping me understand this physiology, and also Dr. Scott Morgan. And Dr. Morrissey got me in touch with Dr. Daniel Cox. Dr. Daniel Cox is an adult congenital cardiologist at the University of Utah, whom I interviewed to gain more understanding of this topic. And I want to especially thank all these people. But most importantly, this has been easily the best 2.5 years of my life, and I'm extremely grateful for the training I've got here. So let's dive in and get started. So first I want you to meet a 35-year-old woman who last year during COVID had a concomitant heart and liver transplant. She was born with a hypoplastic left heart, and she survived enough to be listed for a transplant. And the reason I want to bring this up is she's incredibly happy. After she got a cardiac transplant. This is one of the reasons that I'm desiring to pursue cardiac anesthesia, is you're giving these patients another shot at living. She would otherwise have died prior to becoming 40, and hoping, all things considered, she's going to make a strong recovery. And the reason I want to show this picture is sometimes we forget about the humanness of taking care of these people, and she has to get a large amount of procedures in order to have a shot to smile like this. And so it's very important that we understand this physiology so that we do no harm and we can get her to a position where she can spend more time with her family. All right, so on the agenda today, we're going to talk about a few things. The first is we're going to talk about some statistics. And you may be thinking to yourself, single ventricle, Kyle, you always do this, you always go talking about some crazy stuff. I don't think it's crazy to talk about. There are currently about 70,000 patients worldwide that have single ventricle physiology, and that number is going to drastically improve or increase over the next 30 years. So the survival rate above the age of 30 is upwards of 80%. Currently in the Valley, we have 150 single ventricle patients, and we have 300 patients that within the next 10 years will be over the age of 18. So that's 450 single ventricle patients that will all come to the big house, they'll all come to the hospital, they will not go to primaries for their care, and their other procedures that they will get done, they'll come to our hospital because we are the only hospital that, not the only hospital, but we are one of the major hubs that will take care of these folks. Also, single ventricle physiology celebrates its 50th anniversary year. So the first Fontan patient was performed in 1971. So this is going to become an increasingly challenging topic for all anesthesiologists. So we're going to define what actually is a Fontan. And a Fontan is essentially where you have a single ventricle that functions, and we'll get into the classification. There's a bunch of different types, but we're going to talk about the palliation steps when they're a baby, and then the sequelae of their palliation. We're then going to talk about what do they present for? What do they actually come to the hospital for? That way you have an idea of what you can expect with their end organ dysfunction. And then we're going to talk about how to optimize these patients. This is a crucial step in their perioperative management, and it's important to know when they're optimized and when they need to see additional cardiologists prior to coming to the operating room. And then finally, we'll discuss some intraoperative management on how to best take care of these folks in the operating room. So I have a couple pictures here, and it's very easy to get confused by the complex anatomy and physiology. My goal in this talk is to give you a very simplistic view of a complicated topic. This is usually a super specialty within pediatric anesthesia, but as a regular adult anesthesiologist, this still falls in the scope of what you are eligible to take care of. And so here on the left, we have a couple different conditions that you may have two anatomic ventricles, but only one functions. So on the left, we have pulmonary atresia. In the middle, we have aortic atresia and Epstein's anomaly. And then it gets even more complicated where you can have true univentricular hearts. You can have hypoplastic left heart, which is seen in the upper left. You can have tricuspid atresia, which is seen in the bottom left. You can have a double inlet LV. And then on the right, you can have an unbalanced canal. This is super complicated. And you're probably thinking, how in the world do I simplify this to, come up with an anesthetic plan sometimes in under 5 minutes to take care of somebody? And I'm going to simplify it. So the first thing that we're going to ask ourselves is, what is the systemic ventricle? So this is either a systemic left ventricle or a systemic right ventricle. And the reason that that's important is the systemic left ventricle is a ventricle that can generate a higher amount of pressure to perfuse the body and also the coronaries, the brain, the kidneys. A systemic right ventricle doesn't generate that amount of pressure, and so you need to understand that you may need additional inotropic support if you're dealing with a systemic RV. So that's the first question that you should ask in your perioperative assessment when you're looking them up. And then what palliation step are they in? And we're going to go through the 3 steps to get to a Fontan, and hopefully I can explain it in a simplistic manner. And then we're going to ask the question, are they optimized? This is a very, very difficult question, but hopefully one that I can simplify. And then the last thing is, whenever you get a congenital heart patient, always draw out their heart. Draw out where the blood is going, draw out all the pressures, draw out what are your hemodynamic goals, because once you draw it out and you know where the flow is going, you can better adjust to how you're going to manage them in the operating room. Okay, palliation step 1. Now, try not to get lost. The overall goal, if you were to say one word, is more blood to the lung. That's it. So all of these steps are getting more blood to the lung. So on the left, we have what's called a Norwood procedure with a BT shunt. That's the brown little shunt there. And then you have a sono shunt, which is right here where it connects from the PA to the RV. The purpose of the Norwood procedure is to get additional blood flow to the lung. So you can either have a BT shunt or a sono shunt. What's important for the adult anesthesiologist is not which procedure they performed, but understanding that they will sacrifice oxygen, they will sacrifice systemic outflow to get blood flow to the lung, because these kids don't oxygenate well. So this will be done right when they're born. So there's 2 steps. This is the first procedure. It's called a Norwood. They also perform an atrial septectomy, so they pop open the atria if there's not already an ASD present to allow mixing and better oxygenation. Once that's popped open, then they're allowed to mix, and they can go usually about 6 months, but I've seen reports up to 2 years before they go to step 2. So first step, Norwood, more blood to the lung. Next step. So what they're going to do is they're going to do a procedure called a Glenn. Now, keep in mind, I want you to just focus on the superior vena cava attachment. If you think about a 6-month-old baby, they have a massive head. And a lot of their venous return, 2/3 of it, is from sort of the top half of their body before they get into relative differential growth. And so what ends up happening is they connect the superior vena cava to the PA. Once again, the main focus, get more blood to the lung. So 2/3 of their venous flow is now going straight passively to the lung. And the reason that they can't connect the IVC is it's too much blood flow. They'll overwhelm the little baby's lungs, they'll get pulmonary congestion, and they won't be able to, their pulmonary vascular bed won't be able to tolerate that amount of blood flow. So they pop off this BT shunt, it doesn't exist anymore, or they pop off the sono. And so now what you're left with is 2/3 of their venous return is going directly to the lungs. A third from the bottom half, from the IVC, is still going to their native heart. So second step, we're getting more blood to the lungs. This happens at 6 months to 2 years. Third step, now this is where we get into the Fontan. So now we have the top half connected from the Glen, and then now we're going to connect the bottom half IVC, and we're going to connect that straight to the PA. And so what this does physiologically is you have all passive, non-pulsatile venous return to the lung without any chamber that pumps it actively. So basically, main goal, pump more blood to the lungs. So now that they have differential growth, this procedure is done at about 5 years old. This will now connect all blood flow to the lung, and so you are left with a patient who has passive blood flow to their common atria, and you now have a systemic univentricle that pumps blood to the body. And so let's talk about the physiological manifestations of that, because it's incredibly important. There's a pressure gradient, which is relatively higher from the vena cava to the common atria. Now, the vena cava system is not a high pressure system at all. And so you're dealing with very, very low amount of pressures that are driving this. The other thing is you have chronically elevated systemic venous pressures, and you have a decreased cardiac output. So you're starting to understand a little bit of the physiology now. So why do they present to us? Well, if you take call or you work at an academic center, they can come for anything. They can come from non-cardiac surgery, lap appies, cholecystectomies. They're not immune to the regular surgeries that they present for. A lot of times these patients have pacemakers, and so they'll come to the electrophysiology lab. And like I said, emergency case, if you take call, you got to be ready for anything. And so being aware of this physiology, if you're a night float person, if you're an OR1 person, anything can happen from 3 p.m. to 7 a.m. They'll also present with a lot of hepatic disease. They get a lot of right-sided congestion, and it creates a lot of problems for their liver. We'll talk about that in a second. And 50% of them have renal failure by the age of 25, and of course, they can get pregnant. And I think one of the things that's often overlooked is a lot of these patients, although they're encouraged not to have children, dealing with a single ventricle patient from an OB management perspective is something we should all be aware of. So I want to first mention their neurological sequelae. We're going to talk about end organ dysfunction one by one, and we'll talk about it. So because they had an atrial septectomy, they're not immune to paradoxical embolization. Sometimes they can have strokes even at a young age, and they're just really hypercoagulable. The other thing, it's important not to overlook their psychiatric sequelae of their disease. These are patients that have been in the hospital their entire life. They've had procedures, they've been poked a million times. A lot of them suffer, unfortunately, from anxiety, depression, PTSD, and so they may not be able to tolerate a MAC. They may not be able to tolerate even mild sedation, and so this needs to be considered in your anesthetic plan. So let's talk about the electrophysiological problems with a single ventricle patient. About 65% of them will develop some type of atrial tachyarrhythmia in their lifetime. This is remarkable. Now, you're probably thinking, okay, let's say they develop AFib RVR. What's the big deal? A lot of patients go into AFib RVR. They are so preload dependent that they do not tolerate the lack of diastolic filling. And so you have to have a plan, either pharmacologically or using cardioversion, to get them out of that rhythm. A lot of them live in AFib, and so they're systemically anticoagulated, but you need to have a plan as to what you're going to do should an AFib RVR, an SVT, even a sinus tachycardia. What are you going to do to correct that rhythm? And we all know how to treat these, but this is important to remember. The other aspect is sinus node dysfunction. About 40% of these patients have pacemakers by the time they're 25. But the sinus node dysfunction, it can happen without a pacemaker once you induce the patient. According to Daniel Cox, he's had quite a few patients that undergo profound bradycardia after general anesthesia, and having an idea of what you're going to do if that happens. And what I want to talk about is bradyarrhythmias. So we know the algorithm for how to treat bradyarrhythmias. It's well within the aspect of what we're comfortable with. The problem with the single ventricle patient is that they have had now, by the time they come as an adult, at least 3 sternotomies. And so if they're not converted with pharmacological agents, then you're going to have to transcutaneously pace them through all this scar tissue. And the backup is a transvenous pacer, but you can't do a transvenous pacer because their architecture is jacked. And so you can't float your transvenous pacer into the RV because you'll perforate the PA and they'll die. So epicardial lead placement is your backup, and epicardial lead placement is challenging because you can't easily access a midline sternotomy. That's going to take some time. You may not be able to go subxiphoid to get epicardial leads in. And so if a lateral thoracotomy approach is an option, but not a great one. And so the reason I bring this up is you have to always think about worst case scenarios. So consultation with some of the CT surgeons about if you're really worried about somebody with really bad SA node dysfunction who doesn't have a pacemaker, this needs to be at least a discussion in the perioperative conversation or something that you think about. The other thing is they can develop valvular problems. They can develop their native heart, AV valve regurgitation. If they're a systemic right side ventricle, they can develop neo-aortic stenosis, which will effectively cause some pulmonary hypertension, and also understanding that if they get endocarditis, there's very, very little chance that they will be able to have a transplant in the future quickly. And so always protecting our patients with giving some antibiotics if they need it. So I want to talk about now the pulmonary complications. And a lot of these patients come in with pulmonary hypertension, congestion. They have, chronic oxygen therapy. I want you to focus on PVR. So the low flow pulmonary bed is extremely reactive to changes in PVR. We know this from our boards. The things that affect PVR is tension of oxygen, tension of CO2, pH, temperature, surgical stimuli. So rapidly adjusting their PVR is extremely important. The other thing I want to focus on is the effects of positive pressure ventilation on passive venous return. When you increase intrathoracic pressure, you impede venous return. Now, we discussed already that these patients have very, very low venous return that's entirely passive. And so the effects of positive pressure can sometimes cut their venous return in half. And so if you can get away with either a regional anesthetic, a MAC, so they maintain negative spontaneous respirations, that can help you a lot. And I have a video at the end that will talk about ventilatory management that will hopefully make it make sense. The other thing this is scary. So this only happens to about 5% of single ventricle patients, but they develop what's called plastic bronchitis. And what this is because they have end organ liver dysfunction, which I'll go into in a second, there is proteinaceous material that leaks through their lymphatic and pulmonary beds, and they literally get hard casts. And the reason I bring this up, if you have a patient under general and all of a sudden you've got peak airway pressures that are 50, your oxygenation's in the toilet, and you pass a soft suction and you get stuck, it may be a cast. And so put a big tube in and be aware that this may be a very, very rare, but this would be a catastrophic event if this is not on the top of your differential. So I want to talk about the hematological effects. These guys are really prothrombotic. They have a lot of stasis. We learned in medical school about the Virchow's triad. So they have hypercoagulability, stasis, and endothelial dysfunction. By the time they come as an adult, many of them, if not all of them, are systemically anticoagulated. So you need to understand that may have to factor into whatever it is that you're doing. They also have, it's paradoxical, they have thrombocytopenia, but they have a very active platelet. And so they're prone to clotting. And so this will come into play on the OB floor if they're too thrombocytopenic to have an epidural. And then they chronically are cyanotic, so they get, a lot of times they're polycythemic, they get secondary erythrocytosis, and they're at a hemorrhage risk because their liver doesn't work, usually at the end of as their Fontan progresses, and so all the factors that their liver makes, so it creates a lot of problems. So because their liver is congested, they get a lot of fibrosis, eventually cirrhosis. A lot of them will have hepatocellular carcinoma at a young age, so they may come in for a big hepatic resection. And so this may be something you see, a lot of scopes, a lot of colonoscopies. These are the things that they'll present with. And then finally, protein-losing enteropathy. So if they have protein-losing enteropathy, this will actually put them to the top of the transplant list. This is a huge problem. If they get protein-losing enteropathy, their oncotic pressure from the loss of albumin from their liver creates intravascular depletion. We have already talked about all the problems with their venous return. And so if you have an intravascularly deplete patient who bleeds like stink and they develop this PLE, this can really, really affect your intravascular volume and their optimization. And then their renal disease, they're always cyanotic. A lot of them are on dialysis by the time they hit 25, and obviously avoid any renal medications. So let's get into the optimization things of this. Dr. Daniel Cox really helped me understand what he does. I have a picture of him on the next slide, but these patients absolutely need day or night an adult congenital cardiology consult, no matter if you're going emergently or not, because they will be a source of reference and a source of expertise because they are most familiar with dealing with this patient and they can help out a lot. So that's the first thing that needs to happen as soon as they hit the door. Their functional status, this is super hard, but something that I had a hard time wrapping my head around. And Dr. Daniel Cox said, I just ask them how they feel. And I said, okay, so you want me to take this patient to the operating room and you want me to ask them how they feel? And he said, yes. A lot of times, these patients, they have a range of optimization, but usually they're very in tune with their functional status, and this is the best indicator on when they're ready to proceed or not. And it's hard to believe, but all the tests, echoes, they can cath the actual Fontan. So if they have a pressure of 10 on the cath on the Fontan hasn't failed and they're ideal. They usually have a CVP range of 20 to 30, but it's just kind of fascinating how you just ask them subjectively how they feel, and that's your indication to go to the OR, but that's what he said. And so also it's important to note if the Fontan is fenestrated. The reason a fenestrated Fontan is important is a fenestration is just a hole in the Fontan itself. And the reason that that's important is if the Fontan has a fenestration, you have a pop-off valve should PVR increase rapidly. If you don't have a fenestration and you have PVR increases, you will see it either hemodynamically or you'll have a lot of problems with oxygenation. So understanding if this fenestration exists is important, and understanding if it's thrombosis is important. Yeah?
5 minutes.
Oh, 5 minutes, okay. And then adjustment of NPO status. So this is Dr. Daniel Cox and Dr. Whitehead. They have another guy that I didn't meet, but they're a group of adult congenital cardiologists that are a source of wisdom and knowledge. So intraoperative management. So understanding if you can have a general anesthetic, a MAC, or a regional. These patients, we know that the physiology of what it caused for laparoscopy, so having a conversation that you may not be able to tolerate that hemodynamically, so always have a plan to go open if the patient would need that. Access. Large bore IVs are always reasonable. I've never regretted putting in a larger IV, but you want to have the ability to administer either volume or blood quickly as they are preload dependent. Central lines are tricky. So you can see the superior vena cava. So you can imagine if you place a wire into the superior vena cava and you perforate the PA, the patient's not going to do well. And there's significant morbidity and mortality. So central lines are not without risk. If you put them in, consider femoral so that you don't disrupt this architecture and get the central line out as fast as possible. It's a nidus for thrombus and a nidus for problems. Standard ASA monitors, I don't think this patient, if you undergo general, should get a haircut without an A-line, but PA catheters won't help you. You're not gonna know what to do with the number, and you may not even be in the PA itself. And so it's advised not to put them in. And then just understanding their anatomy is important to know where your wire is going. And then finally, the position. So if you have the option, put the patient in like a sandwich position where their heart is at the bottom, so you allow gravity from the superior part of the body and inferior part of the body to drain blood into the lung, if they can tolerate it, just to totally optimize venous return. So our hemodynamics, we talked about preload dependence, contractility, we talked about the RV or the LV if you need inotropic support. Keep them in sinus rhythm if you can. Open fenestration issues, we talked about that. And then lowering PVR at all costs. This is really how you're going to optimize these patients. Finally, your OB considerations. So I came up with this acronym after talking with Dr. Morrissey, and I call it MD PANDAS. So I keep it in my phone with any patient that has congenital heart disease. And what it is, it's monitors, delivery. So these patients will not push. 100% if they're a vaginal delivery, do not push with them. You'll increase their PVR. They're not going to do well. Do an assisted vaginal delivery, either with suction or whatever they do down there to get the baby out without that happening, or if they're a candidate for a C-section. Titrate in an epidural. Would not advise a spinal, as it's somewhat unpredictable. Manage their pacemaker, their anticoagulation, and then their disposition should be to an ICU. And the reason it is, if they're fine, they're doing well, Dr. Dan Cox on post-op day 2, every single obstetric patient is volume overloaded. They need to be in the CV-ICU or a SICU, and they need to be aggressively diuresed. Once they mobilize that fluid on post-op day 2, they may not be able to tolerate the increase in blood flow to their lung, and obviously antibiotics, endocarditis prophylaxis, and their other additional systemic sequelae. So the last slide I have is on our ventilation strategy. So this is an 18-year-old patient, and I want to keep in mind one thing. We have a mean pressure of 10 at the top right. Our monitors don't show this. So this is a different monitor, but it illustrates the point I'm trying to make. We have on pressure control, we have a driving pressure of 11, we have a PEEP of 5, and we have an IDE ratio of 1 to 2. When you have a single ventricle patient, or for that matter, any patient that you want to optimize venous return, you want to have an increased driving pressure, an increased rate, but you want to sacrifice inspiratory time to allow maximum exhalation periods so that you minimize intrathoracic pressure, and also sacrificing PEEP. So I want you to watch what happens to the mean airway pressure at the top right, and our tidal volumes initially will hypoventilate for a second, but we're slowly going to walk ourselves up, and I want you to watch how this affects the mean pressure. So we're increasing our rate, we're decreasing our IDE ratio, and we're sacrificing PEEP at the expense of minimizing intrathoracic pressure increases. So we're totally optimizing preload here with a PEEP that's going to go to 0, a mean airway pressure of 3, and you're probably thinking, well, we have a tidal volume of 91, we're not even over dead space. These are all things that you can tweak. Tweak them one at a time to where you get to a point where you're ventilating the patient adequately, but you're not sacrificing impeding venous return. So this was over at primaries on a patient with single ventricle, and they just, in a stepwise fashion, increase their ventilatory parameters. And you can do this with any patient that you don't want their venous return impeded. You could do it in traumas, et cetera. That's my end of my show. Thank you very much. And I just want to say thank you again to the department. You guys are absolutely amazing faculty, and I appreciate it.